In your health. I'm your host, Dr. David Bertone. Today we're going to talk about a very important topic, a national epidemic that's going on, and it's obesity. Everyone has had some touch with obesity in their life, either a family member or themselves, and they've tried different things to lose weight, fad diets, different exercise programs. We're going to learn today about a physician-directed weight loss program and how that can be helpful to lose weight. Our guest today is Dr. Claudia Huegel. Dr. Huegel is board certified in family medicine, and she started a practice in Shrewsbury called Metamorphosis to help people lose weight. Dr. Huegel, welcome to the show.
Thank you.
So tell us about your background and how you got involved in weight loss.
Okay, so I've been a physician for about 12 years or so. I started out in the primary care setting as a family physician and realized very early on in my career that almost everything I was treating was related to being overweight. And, you know, I didn't feel like I had a lot of tools in my arsenal to help my patients. But also, in my own life, I've always tried to lead a healthy lifestyle, exercise regularly, eat well. So it sort of hit me like a ton of bricks one day when I was sort of recovering from my own December overindulgence. And I said, you know what, I really should be doing more to help my patients manage their weight and their health would improve. Okay. So I started educating myself, reading journal articles, going to conferences, anything I could get my hands on regarding medical weight loss, and I started working with a small handful of patients and found that they were having success. They were coming off medications, they were happier, they were feeling better, and more importantly, I really loved what I was doing. So I made a decision that was going to be my specialty.
Your passion now.
My passion.
So now, what is a typical workup, or what is the common patient that comes to see you? What's going on with them, and then what do you do to really find out, you know, what's happening with them and how, if you can help them?
So I always start with a consultation. We often will offer a free consultation to a lot of our interested clientele, and they'll come in and sit with me and my staff, and I'll basically talk to them about the program and what it is we do, but I'll also try to understand what it is they've struggled with in the past and why losing weight on their own they haven't been successful, what their specific issues are, and also are they healthy enough to lose weight. So I always start with the consultation. I attract patients that are all ages, male, female. I do treat children as young as 8 years old, and I would say my practice is made up of about 50-50 men and women. Okay. But usually there is no typical patient. I would say if I had to put an average, maybe women and men between the ages of maybe 40 and 60 who are looking to lose anywhere from 40 to 80 pounds. But if someone has 10 pounds, that last 10 pounds after they had a baby and they just can't get it off, or 200 pounds, we've dealt with everything in between. And so as long as somebody is motivated and is looking for help, we will try to do whatever we can to do that.
So after that initial kind of consultation, what's special about what you do at that point? Is there, after that, where I'm assuming you do a full evaluation, maybe with chemistry, blood work, or an exam? Take us through that process.
So once the patient decides that they do want to work with me, and my staff, they will make another appointment to come in for a full medical evaluation. I spend usually minimum an hour with a patient on the first visit, and I do a full medical evaluation, like you said, very detailed history, physical exam. I do body composition analysis, where I have a special machine that not only tells me their weight, but their muscle mass, their fat percentage, their body water. It calculates how many calories they burn. So that way we can give them all that information and follow that every time they come in and make sure that they're losing fat, that they're not retaining water, that they're not losing muscle mass. And then I will sit with the patient, and based on their wishes and their schedule and whatever information they bring me, we work together to put together a customized plan. Everything that we do is based on each individual's needs, and that's really one of the things that makes us very special. That it's not a one-size-fits-all approach.
Okay.
Everything we do is customized to each individual.
Now, you spoke about this specific machine. Is that instead of, say, the old method of skin fold measurements or taking circumferential measurements? Do you still do that, or is that?
No, we do use the body comp analyzer, which works by sending, you stand on the scale and it sends an electrical current, a very small electrical current through your skin, and measures the resistance of that current through water and through fat.
Oh, cool.
And then there's an algorithm that calculates the information and gives us a readout. And then we use that information, like I said, to make sure that the patient's losing fat, and it also tells me their metabolism, so I can calculate based on their body how many calories they require, how many, in order to put together a diet for them.
Yeah, because that information, I'm assuming, is really critical to help with designing the program. Because when you go to a typical, say you go to somebody else, say a nutritionist, whatever, and you're not getting that detailed of their basic metabolic needs, that can cause some problems with their diet planning, I would assume.
Absolutely.
Okay. Now, so you get all this information. What are some of the typical interventions? I know it's really customized, but what are some of the things that you design? Is it meal planning? Is it appetite suppressants? Tell me a little bit about what you would do for them.
No, that's a great question. So the first thing I'm going to do is customize a diet for the patient, and like you said, some patients want to use meal replacements because of the convenience, and some patients want to use grocery store food, and we'll customize the diet. Now, the body of literature that has been developed in the last, I would say, decade or so on lower carbohydrate diets and really keeping the refined sugar out of the diet has been overwhelming. So we really try to encourage more of that for each patient. So for example, if somebody's on a food-based plan, they will be eating primarily lean protein, plenty of fruits and vegetables, low-fat dairy, and some whole grains. But again, it's, we're going to have to see how their body handles what diet we customize, and we may have to tweak it as they go, and that's why I always ask for each patient to make a 12-week commitment to working with me, so that we can sort of tweak it as we go. But like you said, we also, as a physician, I have a number of medical tools in my arsenal, such as things like appetite suppressants, but even just utilizing some of the existing medications the patient may be on, maybe decreasing doses, putting them on a diabetes medication that exploits the side effect of weight loss. So I try to look at all of that. And then the most important thing is making sure that the patient is thinking in the proper way. And what I mean by that is that a lot of times chronic dieters have certain thought patterns that are ineffective. So we use techniques based in something called cognitive behavioral therapy to help them, to teach them how to stay motivated on a daily basis, to teach them how to navigate, well, what do I do when I see that I slipped over the weekend and I gained a pound, and do I give up? Do I feel this failure, or do I then say, no, I'm just going to brush myself off and keep moving forward? What tools does that patient need in order to stick with this newer lifestyle? So we do a lot of work on the thinking process and making sure that we shift the way patients think so that they can be successful lifelong.
Yeah, so that's more of a lifestyle change you're talking about there, right? And combining with behavioral modification to really make a long-term change in their outlook and how they're going to respond to different foods and intake and things like that. When you spoke about diet planning, do you give them specific diets, like specific meals to eat, or do you give them typical groups, or how do you do that normally?
So basically, like I said, you know, because so I give them a calorie range usually to start out with. Some of our patients opt to go on what's called a very low calorie diet, which is our most aggressive approach. And I have to be honest, for many years I was not really a fan of this type of diet, mostly because I really wasn't. I had a personal resistance. I felt like well, there were a lot of things that
doesn't seem right if you go too low, right? There's something wrong there.
But and everything that I had learned just instinctually said that this couldn't possibly be a good thing. But then I really started doing research and found that not only when we keep the carbohydrates very low, but also if we keep the calories very low, the body adapts to that process. And when it adapts, we actually start burning primarily fat as opposed to using sugar as the main source of fuel. It's a process called ketosis. And what happens is the patient on 800 calories is not hungry. They're not craving sugar. And I wouldn't have believed it if I hadn't seen it over and over and over again. I mean, true sugar addicts are coming off of sugar and staying off of it and keeping the weight off, because when we reintroduce grocery store food at that point, we're only introducing the right foods. And it's a tool in my toolbox. I certainly don't expect that somebody should be on meal replacements or on 800 calories for the rest of their life, but it's a tool with which to get them to a place where they're metabolically significantly healthier, and then to keep them there. So, but when it comes to the grocery store meals, I usually use a calorie range. Like I said, I get that information by evaluating their body composition.
Okay.
And I talk to the patient about what they're already eating, and the foundation of their meals should be, like I said earlier, lean protein, lots of fruits and vegetables, and we kind of go from there and customize it and build it to suit their needs. If they say, listen, doc, I love chocolate, what am I going to do?
Yeah.
Is there room for chocolate in this diet? So we try to come up with solutions that are really going to help the patient to stick with their plan, and not have to necessarily give up all their favorite foods.
Now, what happens, I mean, I'm assuming that 800 calorie diet is kind of like a body cleansing. You're trying to really jumpstart them, right?
Yes.
How do you deal with them in terms of energy levels and being able to really function at that level? And do you do that, I know it's a two-part question, but do you do it dramatically, or do you kind of gradually kind of wean down to that?
Again, a great question, and it all depends. And that's the beauty of really customizing it. This is not a one-size-fits-all approach. It's not a cookie-cutter approach. So, you know, if somebody is coming off of junk food and fast food every day, and they're going to probably want to transition more slowly into the diet, and that's what we do. And sometimes gradually we'll put them on 1,800 calories, then 15, then 13, and gradually decrease them. Some people love the idea of getting all the junk out and just shock to the system. And they definitely feel it. I mean, there's a couple days where they're going to be a little tired. It usually takes about 3 to 5 days where they're going to feel maybe a little headachy, a little tired. And then when they're reassured, and a lot of it's education, that they're going to feel a million times better, they push through. And again, it's we provide a lot of support for the patient, and they do. They're amazed how on what seems like such little food that they're just bouncing out of bed with tons of energy. They need less sleep. They sleep better, usually within about a week and a half to 2 weeks of being on the program.
Wow, that's pretty dramatic.
It is. It is. It's really amazing. Like I said, it's this alternative fuel use. The body's so smart. You know, if we don't have sugar and the brain prefers sugar, well, what are we going to do? What did cavemen do?
Yeah.
You know, if only animal protein was the only source of nutrients. So the body learned to adapt to that by using fat as the main source of fuel. And it's a very efficient fuel. I just came back from a conference where they talked about Stephen Finney, who's a big scientist in the area of low-carb diets, actually wrote a book about endurance athletes using no-carb diets for performance, and it found that their performance actually just amazing.
Cool.
So, I could talk for hours about
Yeah.
it.
All right, when we come back, we're going to hear more about Dr. Huegel's approach to physician-directed weight loss.
It's harder whenever there's a bigger group. Pretty much a good day for me would be people leaving their hands off of me. I'm always called names. Everywhere that I go, there's always someone calling me names, calling me gay. I've been choked, thrown up against a wall, punched. Nobody's ever tried to help me.
Welcome back to You and Your Health. I'm your host, Dr. David Bertone. Today we're talking about physician-directed weight loss and how to attack the $60 billion industry of weight loss in our country. Dr. Huegel, welcome back to the show.
Thank you.
So we were talking about some of the interventions and diet plans. How does exercise play a role in weight loss when you help design a program?
So, you know, it's interesting. Exercise is really important. But during the weight loss process, exercise it takes care of about 20% of the calories burned versus the diet, which is about 80%. And I mean, it depends on the particular individual. Sometimes it's a little bit more, maybe 30, 70. But it's absolutely mandatory if you want to maintain that weight loss. Then it becomes about 50-50. So my approach is this, especially because a lot of people who are coming to me have never exercised in their lives. So I start very sort of slowly introducing the idea. And how I do that is by encouraging them to either purchase a $10 pedometer or investing in one of these great devices like the Fitbit or the Nike Fuel Band, or the Jawbone has a device, and counting their steps. And then very quickly realize how when 10,000 steps per day, which is the recommendation of the American Academy of Family Physicians, for the amount of steps you should get per day for optimum health, you quickly realize that maybe you're getting 3,000. And I actually had a real shock when I realized that when I'm working in my office and I'm sitting a lot, that I was one of those people, and I thought I was so active. So what it does is it brings movement and activity to the conscious mind, and it makes you more aware. So when you start to set goals, okay, so if right now I'm doing 3,000 steps a day, I'm going to shoot for 4,000. And by doing 1,000 extra steps a day over the course of a week, that's 2.5 extra days of exercise. So I start very slow, and then I build it up slowly, and they'll very readily realize after a month or so that if I want to see those steps, I better go for a walk. And then once they're doing that, they're going to start adding some weights. They're going to start maybe doing a little jogging, a little what we call interval training, where they spend 1 minute jogging, 2-3 minutes walking. Next thing you know, they're ready to join a gym. And when 30-40 pounds are off, you know, after a couple of months, and their energy level's sky high, they're raring and ready to go, so that by the time they get to that goal, they're already involved in a regular exercise program. So we start low, we go slow, and get them raring and ready to go by the time they're
Now, do you have them track that, and do they bring it to you and
Yes.
say, yeah, I'm walking 3,000 steps now, last week it was 4,000 a day,
Yes.
whatever. So you look at that as part of the follow-up.
Definitely, definitely.
And I can see your point about maybe not pushing the exercise in the beginning, especially with the dramatic reduction in calories. Can that cause some problems metabolically? So if they really went dramatically less in the calories and exercise more than normal?
Well, it's interesting because the product we use and also the type of diets we use, we really try to emphasize that they get enough protein, and we calculate that for them based on their activity level. But more so, you know, a lot of these patients who carry a tremendous amount of extra body weight, and also being that I work with an older population quite often, they're at much greater risk for injury. And I don't want somebody to overdo it, be overzealous with the exercise right in the beginning, and injure themselves, and then they're out of the game.
Then they're sedentary.
Exactly.
You mentioned product. Let's talk about some of the products that you use. Are these, you're talking meal replacement, supplements? Describe what you would typically recommend.
So primarily, like I mentioned earlier, patients have the option of whether they want to use a grocery food type of a program, or they want to use something like meal replacements, which are high protein, low sugar, low calorie products that have been engineered and specifically designed to work with these types of lower calorie diets. So they're very satisfying, they're very tasty, they're in the form of shakes, soups, bars. When they hit maintenance, they can, there's a whole line of products they can use, such as pancakes and cereals and chips, things that ordinarily wouldn't fit well into a low carbohydrate or healthier diet, but it makes the patient feel like they're not missing out on their favorite food. So, and they're very satisfying.
So you would prescribe, say, certain groups, and they order it. Is that
Yes.
how it works? And is it something they have to cook, or it's prepared?
No, they're in the, like I said, they're in the form of either during the weight loss phase, we mostly use bars, shakes, and soups.
Okay.
And those are very easy to prepare. The shake is a powder that you would add water to. It could be done in a blender or just a simple bottle, shaken up. So they're very convenient. But this company has engineered the product to have 100% of the recommended daily intake of vitamins and minerals, the right balance of the good fats, the right amount of salt and electrolytes, things like that, so that the patient is healthy.
Okay. What is the cost of something like that? I'm assuming that's a factor, and
Yes.
when they purchase these meal replacement plans, and then that would be in addition to your services, obviously. So
Yes.
is it some kind of a fixed rate, or is it per meal, or how do you charge that?
The meal replacements run about $2, a little bit more than $2 per meal.
Per meal, okay.
And it averages, depending on the particular diet that the patient chooses, to be anywhere from about $10 to $15 per day, which, if you think about it, your grocery bill sometimes might be even more than that. And then if you're dining out or doing takeout, I may actually save you money.
Yeah.
But usually, like I said, we ask patients to make a commitment up front of about 12 weeks. We see the patient on a weekly basis for that first 12 weeks, and the cost of the food is included. So they are making a commitment up front. We have payment plans, we accept all major credit cards, cash, checks, but we also, although we don't accept health insurance, we do help our patients to try to get reimbursement if they have out-of-network benefits.
Okay.
And now it's getting much easier because of a lot of the new rules with the health insurance companies. They are covering weight loss services a lot more readily than they used to.
I would assume like your medical evaluation would be something that could be submitted.
Definitely.
Right, and so that would help them. Let's talk about some things like hormone replacement and their role in weight loss. And I know if you treat a lot of women and during changes in hormones and later in life, how does that all affect a patient with weight loss?
Well, at this point in time, I work together with some of my area physicians who are doing hormone replacement therapy. It is a very complex and sometimes often controversial area. So I tend to work simultaneously with other physicians in that area. I don't prescribe hormones myself, but a lot of times, especially with men who might have low testosterone or adrenal fatigue, I notice that those things improve significantly once they get the weight off. And also, you mentioned women, postmenopausal women, very common area to see a sudden weight gain in a woman who's never really had a problem. And a lot of times we see that they start craving sweets or salts or foods that hadn't been part of their diet in the past. And like I said, along with appropriate hormone replacement therapy, if they wish to pursue that, sometimes getting the refined sugars out of the diet really improve their ability to lose weight and keep it off.
Great. Now, how about the complex medical patient, the one that may have advanced diabetes or some other complicating factors? How do you handle that?
So, like I said earlier, I consider myself to be an expert in the field, which means that all of the patients I see typically have comorbidities. They're going to be the more complicated patients.
Okay.
And I see about 20 to 30 patients a day for the last 9 years of this type of patient. I'm very well versed in working with an insulin-dependent diabetic, a complicated diabetic. I have patients who have congestive heart failure, stabilized. Of course, they have to be stable. They can't be destabilized. Patients who have arrhythmias, and that really speaks to my formal medical training as a primary care family practitioner. But I also am not afraid to recruit the help of my area physicians. Like I said earlier, if a patient wants me to work together with their endocrinologist, with their cardiologist, and work together as a team to help this patient get as healthy as possible, I'm going to do whatever it takes.
Yeah, that sounds like the safe way for these people. I mean, unfortunately, if they go on their own, some fad diets and things with complicated medical histories, and that's when things get really complex.
And a lot of times my area doctors really appreciate, I'm seeing them on a weekly basis, and if I catch something, I can say, you know what, just yesterday I had a woman who had an overactive thyroid. Which is interesting, because usually you see underactive thyroid.
Yeah.
But I immediately said, I'm going to call your primary care physician so she can work it up, and we'll work together to make sure that you get the care that you need for this issue.
Sounds like a great approach. How about, we've done some reading about HCG, and that is being a little bit of a fad for weight loss. Tell us about what this is, and how is it being utilized, and is there any evidence that it can be beneficial?
Very good question. HCG, which stands for human chorionic gonadotropin, it's actually a protein that the body makes normally when a woman is pregnant, which is very interesting. But there was a gentleman years ago by the name of a physician by the name of Dr. Simeon, who developed a protocol using this. He tried a number of different substances. The diet is the HCG is paired with a 500-calorie diet.
Wow.
Very, very restrictive. So it sort of fell out of favor for a long time, and in the last, I would say 5 years or so, has really made a comeback. And the only thing I can say is that it is not FDA approved for weight loss at this time. A lot of people can get things on the internet and have tried it and had good success. Do we know if it's from the diet or from the HCG? No, we don't. I understand that there are some studies being conducted as we speak on this area to find out more and learn if this is something that we really need to be looking into. And as a practitioner in this area, I have experimented with it in some of my more recalcitrant patients, and I've had mixed results.
Okay.
I've also found that after a while, patients do build up antibodies against the HCG when it's exogenous, and it stops working after a while, which could be really upsetting for a patient who was having such good success and results with it. So I've abandoned it for now.
Now, I'm assuming the FDA, the Federal Drug Administration, doesn't approve or sanction that. Is it something that's regulated? HCG?
Well, much like, it's interesting, much like, because HCG is prescribed for other things.
Oh, it is, okay.
Yes, but much like we as physicians will prescribe things off-label, it's the same idea. So it's not something that a physician's going to get in trouble for using, but like I said, because it hasn't really been scrutinized, and I try to practice evidence-based medicine, and because the evidence just isn't there, I'm not as comfortable as I'd like to be.
Okay. Now, one of the last things is, what's the key to maintain people once they lose the weight? You get them down. What's the process like? What's the follow-up like? We know it's behavioral modification. What happens at that point?
Well, Dave, it's my magic pixie dust, which actually my staff always no, but there's no magical secret to any of this, as I'm sure you and your audience would imagine. But there are some really important things. I did mention a little earlier about exercise and making sure that you have a good program in place. The cognitive work is essential, and really making sure during the process that the patient is actively making that mental shift to, this is my new way of life. And I always use the example of an insulin-dependent diabetic who's on 3 medications and has finally gotten their blood sugar under control, and they go in to see their doctor, and their doctor says, okay, Mr. Jones, everything's under control, you're done. I never need to see you again. That's so crazy.
It doesn't make any sense.
It doesn't make any sense. You know, there's going to be, you know, maybe that patient has an illness and their blood sugar starts to go out of control. They need to see their doctor more often. It's no different. I'm not 100% sure if I feel that obesity is a disease yet. I haven't adopted that belief yet.
Okay.
Although I was just with Dr. Ethan Lazarus this past weekend, who actually went to the AMA with this and was the one who got everything changed over.
Okay.
But it is a chronic condition, and it has to be treated as such. It needs a chronic solution. And so the real key is ongoing support, ongoing attention to the diet, being conscious every moment, every day. It's how I live my life. And sometimes I don't want to eat a salad for lunch. We were talking about pizza. Sounded really good. But you know what? Sometimes we don't want to do it, but we know if we want to feel good and look good and be healthy, it's just what we got to do.
Great. Thanks for joining us.
Okay, thank you.
You've been watching You and Your Health with our guest, Dr. Claudia Huegel. I'm your host, Dr. David Bertone. Until next time.